Good morning from New York, or good time anywhere you are around the world. Welcome to the Structural Heart Live Case program for Mount Sinai Heart. We're about to show you a very exciting TAVR case, but before that, let me go through some logistics. I'm George Dangas again from the control room here in the Cardiac Catheterization Laboratories. I'd like to let you know that next week on Tuesday, we start with the Coronary Live Case program at ccclivecases.org. ccclivecases.org, same time next Tuesday. And next week we have a special live program from the 17th to 19th, Wednesday, Thursday, and Friday at the Manhattan Equitable Center, very close to Times Square. And that will be a live case course. And you will see both vascular, structural, valve, as well as coronary cases performed. Of course, get a chance to meet all of us, the entire team of Mount Sinai Heart Interventional Cath Lab and associates on site, and talk about the cases or the latest data from that affect clinical practice from the clinical trials of this past year. Before I then go to the cath lab, I also want to say that anytime you have a question, just send us an email at info@structuralheartlivecases.org. info@structuralheartlivecases.org. Just send an email and I will be happy to pass on your question to the operators either directly or put it into the discussion indirectly. As well as you should know that this case will be posted shortly after its completion at this website where you are right now. And you can find it in the archives, exactly where you can also see all our previous structural heart live cases performed live thus far. So without any further delay, let's go to the cath lab and welcome Dr. Sharma and associates, and Dr. Kinney, I see, to this today's program.
Yes, good morning, George, and clearly this is our fifth of the structural live case, and we're very excited. And of course, we're having every 2 months appearance, and we'll see. With the interest, just like coronary, maybe we, towards the year end, we might make it every month. But we are not only this week, the next week also a lot of activities as you mentioned, and we really encourage of our participants to those who wants to take a trip to New York, or definitely to log in for the live case, but clearly series of cases on 18th and 19th will be tremendous educational experience. Now with that note, our players here, everyone knows, although the camera actually not showing everybody's face, so yeah, good. Now great, we are ready to start the case, but Dr. Kinney is on my left side, Dr. Ani Anwani on my right side, and Jason on further, who is the tallest in the room, and then Juan Terre, the fellow in the back. The key is we start with the case and go through the various technical tips and tricks, and in the end, when time permits, I'll talk about the neurologic complications or issues with the TAVR and how we can manage them with the emerging strategies. So with that note, why don't we start our the slide presentation. Next. So basically, is an 86-year-old patient who had progressive exertional dyspnea for last 3 to 4 months. And has a recent exacerbation. Patient has AFib, DVTs, and TIA. You see it. Also, patient was a little intolerant. He used to be on warfarin, intolerant, so he was an appropriate case for the Watchman device, which was implanted about 3 weeks ago. An idea there is that you may take him off various therapies that particularly because patient also had a PCI, so needed to be on triple antiplatelet therapy, aspirin, clopidogrel, triple therapy, and initially was warfarin, then was changed to rivaroxaban, and various other medical therapy is there. The idea is that of the Watchman, that after some time, they usually say 4 to 6 weeks, you can take off the anticoagulants, so that hopefully after this procedure, we'll put patient only on aspirin and clopidogrel. Clearly has a severe aortic stenosis, and you'll have a chance to see a little more on the live on echo. And the cath has a 1 vessel PCI, which I did about a few months ago of the LED diagonal system, and he has done well from the coronary point of view. Next. The CT angio, clearly a large femoral arteries, and also a big annulus, and so that is a large valve with STS risk mortality as shown here, 4.6, although on lower side, but it still felt to be high risk for surgical AVR due to advanced age, frailty, and pulmonary hypertension. And patient is planned for 31 millimeter CoreValve by the percutaneous access and the conscious sedation. Right? So far, we are under conscious sedation. Sometimes we start with conscious sedation, but our anesthetic colleagues may decide that patient is very unstable, uncooperative, they are hemodynamically, so make a decision to intubate. So there's nothing wrong in these cases to intubate, particularly to get your procedure safely and without any additional added complications of emergency intubation. So if decision is made to intubate, to me is nothing wrong in that. Next. So now this is echo, and actually Partho is on the echo side. Maybe he can show not only the echo findings which we have and the live on the echo of the valve. I see all the fancy things being shown there with 3D.
Sharma, the team on this side comprises of my associates, Dr. Amanda Reed, who's the cardiac anesthetist. We have Dr. Hinchley, who's the cardiac anesthetist fellow, and my own fellow, Dr. Brandon Wiley. And what you're seeing right now is the three-dimensional echo. This is showing the Watchman device, which is well seated. There is no thrombus. So we are confirming first to start off the previous findings. And then this is the four-chamber view. The left ventricular function is very well preserved. Biventricular function is well preserved. Biatrial enlargement. And then you go to the long axis view, which shows the aortic valve. Now, what you can see here is not only the aortic stenosis with severe aortic stenosis with mild aortic regurgitation, but also there is a very prominent basal septal bulge, which is very clearly evident here. There is no systolic anterior motion. There is no turbulence in the alveolar outflow region, but this is an important information because this septal bulge will have a tendency to push the valve upwards. So this information has been provided to the CAT team to decide for the deployment strategies. And then we go ahead and we have measured the septal bulge. It's almost about 1.5 to 1.8 centimeters in outflow, but there is no LV outflow obstruction. And we have done subsequently a three-dimensional analysis of the aortic valve. And what you can see here is the aortic root, where this is the left main ostium. The left main ostium is about 1.9 centimeter from the annulus. And if you look into the annulus per se, it's a large annulus. So the overall circumference, so this is the view, which is the short axis view of the annulus. This is a very carefully, very meticulously performed 3D, where we use a turn around rule, and the circumference is 9 centimeters, area of 6.4 centimeters square, and the two diameters are 3.1 and 2.7 centimeters. And this is, we do perform it blinded, independent of the CT data, and we'll confirm with the CT data as the annulus is presented there. And so overall, severe aortic stenosis, the gradient on the TEE is 4.1 meters per second, and so we are confirming the severity of the aortic stenosis. And again, the cautious thing here is the bulge. Plus, in addition, there is also some moderate to severe calcification of the mitral valve leaflet, particularly near the right and the non-coronary commissure. So that information is also important. But the annulus per se is not extremely calcified. So
okay.
Now it's important to maybe we can ask Jason or someone else to tell us now that we have fresh in our memory the echo measurement. What were the CT angiogram measurements?
Actually, you know, the echo gradient is about the same. But I think there is a very important point here, and which we are encountering, and there are some in the literature now, knowing that when you start doing more and more cases, the anatomical issues come up, and one of them is coming as a septal hypertrophy concomitantly present with your severe aortic stenosis. It's not only some of the time, it is also HOCM causing some obstruction, but even if not, there is a tremendous septal hypertrophy and along with a severe aortic stenosis. So there's no question that the gradient is caused by AS, but maybe some contribution, and if there is a large septal hypertrophy significant, how to deal with it. I know that Anu has done one case and has something about the learned with the literature. Anu, how do we deal with this, and should we combine in some cases as a septal ablation, alcohol septal ablation before, knowing that these are the non-surgical cases?
Yeah, I think this kind of case is very important to differentiate the septal hypertrophy. Is it due to AS itself, or it's a combined, especially you see this elderly women that you have mid-cavitary obstruction because of the basal septal hypertrophy, and then there is, they usually come with the moderate, but not real severe AS, but moderate AS. We have had a couple of cases like that, and I think you go with the usual, criteria where you have to have at least some basal mid-cavitary gradient, about 30 millimeters or more, and of course post PVC you will have to differentiate that the gradient is different from AS when you do a nice pullback. These kind of cases, that what we have done is did septal ablation before, and you see if there is any symptomatic relief in this patient, and if there is still no symptomatic relief, that means your AS remains the same and they did not get better with regards to their exercise tolerance, then we have proceeded with the TAVR in these patients.
Now the question in this particular case is a 31 millimeter valve which tends to go a little dive down. How are we going to deal with this hypertrophy and the valve?
Yeah, that is another important technical part which we always discuss with the echocardiographer, that how bad is the septal hypertrophy and exactly where do we place the, where do we start releasing the valve. This is always a problem, and how thick the septum, what is the thickness of the septum and where do we place the valve. Is it at the mid part of the septum? You start releasing at the mid part of the septum. There are a few cases where it has moved up because it pushes it up, versus if you go the lower part of the septum, it will be too low. Usually what we tend to do is start releasing just at the mid part of the septum, and since it is 31, we just hope it will stay there. Even if it comes up, I think we'll be okay, that it will not be above the annulus.
Now Ani, I know you have tremendous experience with this aortic surgeries, and so do you often encounter or infrequently encounter incidental septal hypertrophy, and do you do some myomectomy in patients who are getting a surgical valve replacement?
Yes, we do. If this patient we're getting surgery, we'll do a limited myomectomy to take away that bulge.
Okay.
Well, we'll do it just because we're there, not because it's indicated separately. Yeah.
But key is that philosophy is there that if there is a too much bulge, it just do a limited myomectomy.
Just to because even though there's no turbulence, by definition, it is restricting the outflow to some degree. So we'd always take care of that. But I don't know that there's evidence that that makes a difference. So in this case, replacing the valve alone should fix the problem. I don't think the septum is
I just want to underscore one other thing, the question that you mentioned, that do you do septal ablation and TAVR at the same sitting? I personally think you should not do it. Do it at two separate sitting. If you know that you are dealing with the mid-cavitary obstruction and AS in that particular patient, this is that you do septal ablation, see if there is any improvement of the patient's symptoms. If not, proceed with the TAVR later on. Compared to when you see a mid-cavitary obstruction that you see because of some basal septal thickness which happens after the valve placement. That's a different entity where you may have to, where the reports have been there that you may have to have do septal ablation post TAVR.
Yeah, but that will be a little difficult, right?
Yeah.
I mean, if you decide to do it pre. Okay, now we can go back to our slides, and JK, you take us through your other CT, meticulous CT measurements, which are integral part of next.
Next slide. So yeah, we of course do very careful CT planning and start with obviously the annular size. And as Partho just mentioned, from the echo, he got a perimeter of 90 millimeters. We got exactly the same by CT there, and you can see that. Importantly, I think the CT gives us very good, precise assessment of the extent of calcification in the annulus itself, and while the leaflets have a lot of calcification, the annulus itself has only mild to moderate spotty calcification, as you can see there. And again, consistent with the echo measurements, we got diameter measurements. The maximum is about 31 to 32 millimeters. The minimum is around 26.5 millimeters, giving us a mean of 29 millimeters.
Exactly what Echo said.
Exactly the echo.
Yep.
Next slide. So it's not just about the annulus. We have to get a lot of measurements to make sure the patient is appropriate for a 31 CoreValve. We check the ascending aortic diameter, which is 32 millimeters, which is appropriate. The angle of the annular plane to the vertical is 45 degrees, which is reasonable for proceeding with TAVR.
This
Next
is a
slide.
very key slide, actually, because this is going to help us understand how the valve is going to enter the LV.
Sure.
And having it not a very orthogonal is great. This is a great slide and a great knowledge to have, the angle.
Yeah, 45 degrees is fairly average. Not too vertical, not too horizontal. Next slide. So then looking at the sinus diameters and the sinotubular junction heights, we've got a sinus of Valsalva diameter of around 39 millimeters, which is certainly adequate for this, for a 31 core valve. And you can see there the calcification on the leaflets more precisely, which is where the bulk of the calcification is in this patient. And the sinotubular junction height is adequate at around 25 millimeters. Next slide. Critical slide here, the coronary ostia height. The left main height is around 16 millimeters. The right coronary ostium height is around 14 millimeters. Anything above about 12 to 13 millimeters gives us confidence that there's low likelihood of occlusion of the coronary ostia. So this patient would be at low risk for coronary ostial occlusion. Next slide. And so to the access, the patient does have a right hip replacement, which is giving some artifact on the right side there, but you can see the femoral vessels there nicely outlined with diameters of around 9 millimeters, both sides. Next slide. And you can see here in the 3D that the vessels are a little bit tortuous, but nothing too bad. Widely patent all the way up and no calcification. Next slide.
Yep.
So here you can see the overall putting everything together. Next, just click advance. Our patient fits into the 31 millimeter. Click next. 31 millimeter bracket by all accounts. Our patient there, you can see the numbers at the bottom, fits by every parameter the 31 millimeter core valve. Next slide. So just to summarize, Dr. Sharma.
Yep, basically a reasonable appropriate case for the 31 with the 29 millimeter annulus. It's just at the upper limit. You know, if it is beyond 29 millimeter, we cannot do much, and so this is still within 29. And now more and more, in the past, echo actually read used to be 1 centimeter less, 1 millimeter, 1 or 2 millimeter less than by the CT, but now most of them are actually give the similar measurements.
Do you want me to show all the axis? I have it all here.
Okay, just now we are ready. You want to just show the access? Okay, just 1 second then.
So just to show you what we've done so far, we accessed both femoral vessels. Here we are accessing with a microcatheter the left femoral artery. Nice calcium-free, nice access in the mid-femoral head. The right we're accessing here, and again, mid-femoral head, nice access, no significant disease. Because there's been a cath and a watchman done through the right, we ended up electing to go through the left. Here we are getting our root angle shots, checking that we've got the 3 cusps nicely aligned in a horizontal plane. And here we are. This is our final angle shot that we'll be using to deploy the valve. And you can see the very bulky calcification in the valve leaflets. You can also see the watchman device there sitting up above and to the right of the aortic valve. So then what we did is we accessed the left side because it had not been accessed before. You can see here we're advancing a 19 French expandable solopath sheath up through the iliofemoral system. Here we are, and here we are live back with Dr. Kinney.
Wait 1 second. Yeah, good.
So, and here you can see, I'll just go back just to show you the final shot. Here you can see we're expanding up. This is an expandable 19 French sheath. We are expanding the sheath up here to its full diameter of 19 French to accommodate the valve. We've got 2 pre-closed sutures in the left common femoral artery, which will enable us to get closure and hemostasis at the conclusion of the procedure when we take the sheath out. Dr. Kinney.
Very good. Okay. Now we actually have now the AR.
We have the AR2.
AR2 to ready to cross the valve, and we use the same stiff shaft 0.38 Terumo wire, and to cross many time in this when we're using a 31, we go with the AL. So anyone your choice, AL1 or AR2 is the catheter of choice to cross these valves, and then exchange it to a super stiff wire.
Patient had BAV?
No, we never did the BAV in this case. Yeah, we actually have also encountered now that if you did a pre-BAV, pre-TAVR, BAV pre-TAVR, that many times crossing becomes a little difficult, and understandably, because now then the valve restenosed in a very eccentric fashion, and so it's a little difficult. But but it is a very heavily calcific leaflet. Actually, I'm surprised there is almost no calcium at the in the annulus or in the aorta. It's
Exactly. It's
leaflets are very
bulky
calcified.
leaflets.
Yeah.
And you can see here, just for completeness, while we're crossing, we have a temporary pacemaker, which is through the
AL1.
right femoral vein.
Or AL2.
There's a 5 French pigtail, which is through the right femoral artery. And anesthesia has a swan from the right IJ.
And apparently the patient already has a permanent pacemaker.
Already has a permanent pacer, you can see there.
But for logistical reasons, it
AL2
is easier to
no?
pace
AL1.
during the
AL1.
procedure at the high rates we need.
No.
We may need
Change it then.
through the temporary wire.
Yeah.
I would
Yeah.
take
So you still
AL2.
need it
I
temporarily
think
for
it's
a while.
higher up.
Yeah, we tried it. We tried a
Check
couple
it.
of times early to get EP in to reprogram the pacemaker for us.
But too
And,
complicated, yeah.
yeah, the responsiveness of the pacemaker to rapid pacing and off is not very fast, and there was a sort of 20-second delay before the machine would start rapid pacing and things. So we rapidly abandoned trying to use the pacemaker to do the overdrive pacing in these cases.
So now we quickly saw that AR2 was not our the pointing to the basically opening, and how you see the opening, that your wire once come to the outflow tract, you will see the bobbing of the wire and the catheter. See now AL1, boom. So that's the principle is which we should have kept it the same way, that once you have need a 31 millimeter valve, core valve, go with the AL basically the AL1 catheter. Rarely you need AL2, but AL1 is good enough.
Yeah, which you want?
Yep.
This is
Yeah.
regular.
I think
or-
we'll go with this, yeah. Okay. All right, let's see the gradient. The
Is the
hemodynamics.
hemodynamics being shown there?
Yeah, they can show.
Can we keep the hemodynamics all the time?
Your
One
catheter is
screen has to
attached.
be hemodynamics.
Yeah, your catheter is somehow against the wall. Yeah, a little too far. Good. That's good. No, not
Yeah,
now.
that's good actually. Yeah, it's very good. You can show a little bit more at the bottom of the screen.
PA?
Yeah, that's great. We can keep it there.
Okay.
PA is
PA is 40 by 20.
Throughout the case, that'll be great.
Okay, good. So now we are ready. We have made the special curve. Actually, JK has made the special curve because one of the big issue with the we can go back to our usual guys. We can take away. Now, is there
No,
any
no, let
way
the
we can have 3
hemodynamics is
screens there or no?
They have it now.
Yeah. No, but I'm
No,
saying
no.
that they will take away the hands.
We can
don't
have
need
the
hands.
big screen show the
Yeah.
curve Dr. Sharma wants to show.
Yeah. Basically, the idea is that stiff wire that is fully curled. You
Yeah.
know, yep. Let's go in.
Oh, that is really great. The important thing is also not to miss the cheater there so it can really go in.
Right.
Otherwise, it may have a little bit of a problem and you lose the shape.
Can
But
tell
it's
them we have
definitely
shown
was a
all
lot
this
of
in our
art
handbook.
into
Yeah.
making the shape looking so good.
Yes.
Yeah,
And
'cause
actually
they've
all
done
these
but they've done
steps,
another IC2.
We
And
have
the
mentioned it in our practical handbook of of the interventional cardiology that was just that came out early
One
part
more,
of this
ACT.
year.
And then we're making a soon the tower handbook, huh? Okay. Now we do a dilatation with the what size balloon you have?
22. This is a 22 Z-med balloon.
22 Z-Med. So we are going to dilate with a 22 Z-Med now.
So the information about the wire.
How are we with the
position-
wire?
The wire is actually locked in the lateral wall. You'll have to
Okay.
use probably
Use a pigtail? Okay.
pigtail to reposition.
This is
it.
a very important information. Always the echocardiographer will tell us that it has to be in the mid cavity, the wire. If not, you go back with a pigtail and rearrange the wire.
Yeah, and don't try to move the wire without the pigtail or with Emplart's catheter because it will may push against the vessel wall and may create more problem.
LV wall.
I mean with the LV wall.
And you can see how well the pigtail is buckling there around the apex with a goal to protect the wire in a nice way, although of course now it's probably caught somewhere, but
You have to advance
it
the wire.
will be
This
It will
wire
be
you cannot.
improved,
You
uh,
need
No,
the other
but-
wire.
No, but keep
shortly.
it within here. Yeah,
yeah,
one
it
second.
looks like the end of the pigtail is kind of stuck somewhere.
So it's stuck in
So-
the lateral wall in the papillary muscle.
Give me the other
Yeah,
wire.
so you're gonna retract it a little bit and then pull it back again.
Yeah.
So it's
what-
very important to have a nice curve
I can
around the
reshape.
apex,
It's okay, I got it.
Never-
either by the pigtail and then obviously by the
I
wire
mean the
as well.
35 wire.
Yeah, therefore basically again, These are the stiff wire. So you don't want to go with the too much manipulation of the stiff wire itself, the super stiff. So that we have what we are doing now. We have our regular 35 exchange, and we're trying to position the pigtail in a better position.
Derecho.
Yes.
Now it's better.
Yeah.
Right.
It's reached
Good.
the loop
Yeah.
Okay.
at the apex.
Good. Let's go
That
back.
one was mangled.
Yeah. So then now we need to make a loop again.
Look at the
As sometimes happens, that last wire had been badly mangled trying to come out, so I'm just quickly reshaping a new one.
But these are very.
now in the
all the-
fluoroscopy you can see the pigtail, the J-tip is in the apex.
It looks extra step, but I can step, but I can tell you this is very, very vital, and we have learned that over the years that rare complication of your wire perforation can be avoided with this meticulous technique. Okay,
Looks good.
very good.
Okay.
All right, George, any questions being asked?
No, the question was regarding the wire position and all that, but we addressed it very nicely.
Good.
And it's very important to keep the position of the wire stable throughout all these exchanges, and you can see the loop is actually almost perfect for this case, and the balloon goes up.
Good.
And
Okay.
we center it.
Start
in the,
pacing.
We center it around the calcium, and we do this with rapid pacing at
Good.
160 or 180.
Go up. Okay. Stop pacing.
And then after it gets deflated a little bit, it's retracted.
Pressure.
And you can see there's essentially a three-person operation for this to become very fast. One person secures the sheath, the other person continues to have a negative suction on the balloon, and the third person moves the catheter over the wire backwards.
All right,
Mild
bring them
aortic
up.
regurgitation.
Okay. Just position the pigtail now.
And we monitor the PA pressure throughout all that. What's the PA pressure at this point?
So far 40 by 20. Oh, it went up a little. Yeah, good. 40, 45 by 20, and where anticoagulation is heparin with the ACT about 280.
Yeah, it was 298 exactly.
Blood pressure very stable, PA pressure very stable. It's a very interesting indicator, actually, the PA pressure on how things are going in the procedure. If we had a
Go to your
major AI following this or any other maneuver, you could see the PA pressure skyrocket. You can see how smoothly the valve went around the arch and into the LV, and now the camera is moved a little bit more caudal. It went from 5 caudal to about 20 caudal. In
Exactly.
order for the marker at the bottom to become a single line that you can see here, the single dark line,
Take a picture.
right at the nose cone, as opposed to a little oval shape that was before.
Okay,
Because
and
if
now
we no longer see the oval shape, this means we're perpendicular.
we
to the, device.
reposition the pigtail,
Yep.
right?
Good.
And now, Cine,
Yeah. Good. Looks good.
I think this is a good start because the 31 always tends to dive in a little bit more than the other valves of the family.
And in this case, we will try to keep it little same for the same region of the septal hypertrophy that keep less. Clearly, one of the big issue with the low valve is the higher incidence of pacemaker implantation, which is not an issue in this case.
stop here. We are
And
going
then
to go
secondly,
with
of course,
another.
little more regurgitation.
Okay, another angio. Inject.
Yep. So far, so good.
Okay.
Okay. Let's just
Start releasing
I'm
more.
gonna Open till it flares
Yeah.
now, yeah?
Now you flare.
Okay.
This is the time. It will dive. Keep holding. Keep holding. Keep holding. Now it's flare. May dive. May dive. Keep holding tight.
okay.
Good.
Yeah.
Okay, another cine. Start pacing.
Well, this
Okay.
has opened up
Release,
very
release,
nicely.
release, release. Start
And now
releasing.
you have to start releasing it because the valve is closed. And
Yeah.
it's a funny transition time when the valve is stabilized but still closed, because then there are no hemodynamics.
Keep holding tight.
But right now we're very good.
Okay,
Now at
stop
this level the
pacing.
valve is open. It's functioning normally. If we can see the hemodynamics, we'll verify
Inject.
that. There's a nice blood
Good.
pressure.
Okay, come out and release. And I'm going to move forward a little bit.
And
Yes,
here is,
keep
I'm
release,
just holding
keep
the wire.
release,
The
keep
key
release.
is that wire position.
And you can see
It's
the
not moved up.
hemodynamics is
Yeah.
very nice.
Yeah.
The
Go
pulsatile
in.
pressure
I'm
a
going to
little
go in a
low, but
little
it
bit.
doesn't
Well,
matter.
actually
We're
Okay,
also
good.
a little damped there.
No, I don't think so. Coming
Okay.
out.
Bit detached.
Yeah, detached.
Yeah, we're detached, and now take it out. Take it we take
Good.
the system in the descending aorta. As you can see now, we marry the two.
Yeah. Now
And,
coming out.
And then remove it all the way out over the
Arthur looks good.
The position is excellent. We are
Okay.
now going to evaluate the paravalvular regurgitation. So there is evidence of paravalvular regurgitation. So it's underexpanded.
28.
26.
20, we're going to 20.
So
28
the
Zmet if
assessment
you
of
like.
paravalvular regurgitation is
The
moderate
diameter is
to
31
severe.
and 27 and a half.
28 Zmet.
Blood pressure.
Yeah, why the patient is still hypotensive?
So severe paravalvular regurgitation.
Okay, stop it. Let's go. Post.
Well, there is indeed. Can you show the short axis part of that?
Yeah, right now you
He's
can see the
saying-
short
yeah.
axis from
And
10
little
o'clock
local.
position to 2 o'clock position. There is a wide gap,
Yeah.
and you can see it's
Pressure-
underexpanded.
pressure is come back.
Pressure good. Yeah.
Okay, can you pull back your
Yes.
TE?
And we are going to show the aortogram, and then we do the aortogram after post-dilatation.
Yeah.
Okay, ready for injection?
So indeed there was
Inject.
paravalvular leak between 12 and 2 p.m. And you
Yeah.
can see there's quite a
Lot.
bit by the TE as well.
I think the valve position is very good.
And if we have to choose, you can see that the right side, the valve,
What's the balloon you took now?
the valve cage hasn't fully expanded out as on towards the left side, and maybe that's where the little restriction plays
So
a
we are
role.
going to a post dilation 28 Zmet.
Zmet.
And this is
Can
very
you give
important.
instructions?
The pacing instruction is
All the
key at this point.
So we have a question on how this 28 has been calculated. How do you estimate the post-dilation balloon size?
Okay,
Sure.
let's focus on post dilation
Yeah.
now.
Yeah. No, JK can answer that
Sure.
question. Yeah.
So the annular diameters were
This is
31 and a half
important
by
for them to
27
understand.
with a mean of 29. So we really need the 28 to get the full expansion here.
Okay, let's go to the pacemaker.
Pacing.
Okay, very clear. These are derived by the small dimension
Can you show?
of the annulus.
Can you show the pacing screen?
The
Okay,
patient
stop.
is being
Show the
paced at
hemodynamics.
180 right now.
Stop the hemodynamics. Show the hemodynamics. Screen. Good.
Yep. Good.
Okay,
Okay.
now go 160.
So you really want to decrease the pressure.
It has to be less than 50 before you can inflate.
It hasn't fully captured. Now it captures, but the pressure
No,
is still
no.
high.
Amanda, can we go low blood pressure? Okay, stop pacing. Okay, now you want to try 180?
All right.
It's
Or
going up.
140. Go to 140.
140, yeah.
Clearly, it's very important that your the mean PA
have to take
mean
it off.
pressure. Yeah. Off.
Off.
1 second. Yeah. So let's give it a little time. Okay. Do it now.
140.
That's the mean should be about like 70, 80. Pacemaker. Go to 180 now. Okay. Good.
No, no, no,
Go.
no, no.
Why?
Too high. It's like 90. Okay,
Off.
stop pacing.
Somehow we're not able to decrease the pressure. It's very important that we don't go up. Very important detail,
Now it will be okay.
because still the heart has enough
Pressure
power
goes up
and
when
may
you
inject
pace.
the
I
balloon
know,
and the
I've
valve
never seen
together.
that.
Okay. Try now.
Maybe
I think
pace
we can
120.
wait a little bit, and sometimes it falls after some time. Let's wait a little bit.
I've never seen this pacing and increasing the blood pressure. Yeah.
Negative.
Stop.
Negative.
It only goes 165 the pace.
Maybe
by
you
the
can
way.
go 120.
Why
See?
you don't pace at 180?
No, we did
We
180.
did
That one was 180.
But
Go to
it paces at 165.
Now is 120.
It sounds like the pressure is low. Why don't we pace now?
No,
Go.
no, no.
160. Go. Connect the
Yeah.
pacemaker a little better.
Pacer hasn't worked.
Yeah, the pacer might need to advance a little.
Pacer. Advance the pacer.
Oh no, it's in.
It's in. It's capturing.
No, but pace rate. Yeah. Okay. There's 160. And if you go to 180, what happens?
Take it out. Oh.
Now let's go to 180 while we're still in pace.
Good. This is
Yeah,
okay. Good, good,
that's
good.
good.
Very
180,
good. I
good.
think now
Okay,
it
good,
fell
good.
down.
Okay,
Don't
okay,
worry,
go, go,
let's
go. Okay, go.
Has to be
Okay.
a little bit
Okay.
more inside the balloon. Very good. So you can see how it is.
Jumping.
Really,
go, go,
the
go, go.
dot is beyond the end of the valve as it is right now.
Continue
There is
pacing,
a
continue
very
pacing.
big,
Continue
a very
pacing.
long inflation
Continue
until
pacing.
the balloon not only is expanded but also is retracted out of the valve
Continue pacing.
in order to
Okay, stop
avoid any
pacing.
movement. And you can see this was a pacing run, was quite long. Again, you have to make sure the balloon is not only expanded but also removed out of the valve before you stop the pacing in this particular maneuver,
How much is the pressure?
the
Okay.
post-dilation.
Now we are seeing the effect of post-dilatation. This you need a wire to advance this. Wire with the pigtail has come back down. Give me a 35 wire. No, you need a wire too.
I think we can see the skirt of the valve a little bit more open now, and we'll see how the T and other measures show. Blood pressure has
open.
recovered nicely.
All right, Partho, comment on it.
So there is some expansion that was seen. Continues to have moderate paravalvular regurgitation. Still, there is a gap between
don't have
11
to be-
o'clock
Anything
to
bigger, Ricky? Any bigger balloon?
1 o'clock position.
That's the biggest balloon we have.
The biggest is, I don't think we carry even 30. Is there any 30?
No, leave it.
Huh?
Has it changed?
What?
There seems to be a
We do
small
have a
cleft
30 or
there. I
so.
think it has changed a
Okay.
little bit. Why don't we wait a little bit, exchange it for a pigtail and wait a little bit, and I think we may have more of an effect. It's definitely smaller
It's a
than it was
Z-med?
before.
It's a Z-med.
There's the 30 Z-mat.
30 Z-med they
Okay.
have.
Bring it and keep it in the room. We have never done any dilatation with the 30 so far. But maybe this will be. Because remember, it was just at the border 29. We were 29.1. We don't do the TAVR. So it was just maximum which we can
Has
could
it
extend.
changed a little bit? Partho.
Yeah, so it's gone down. It was severe. It's now moderate, but still there's a wide gap.
But diastolic is okay.
Yeah,
We
definitely.
are about 70.
Diastolic is 70, 60,
Yeah.
70. PA pressures are improved, definitely better.
Okay.
Hang on, sorry, it's all fucked up.
It went up.
Yeah, just if we let me just rebend.
Are we showing the hemodynamics? No gradient now?
There's no gradient in the hemodynamic. Go to the hemodynamic tracings.
LVDP?
Yeah. Okay. Now I think it's about time to do aortogram again. Ready? Go. No, but you attached it. Why did you bring me?
Yeah, but you are holding it.
All right, let's do it again. You know, this is high pressure tubing.
Flush, flush, flush,
Sometimes
flush,
get disconnected.
flush, flush.
Okay, let's do it again.
It's a shower after
Yeah, but
this.
definitely very little AI. Less
No
dye.
AI.
Big
The
discount.
standard way to cure AI is give less dye.
Yeah.
Well, the
How do they
diastolic pressure
connect it?
is quite
Very good.
Ready.
Yeah,
It's
yeah.
over
Diastolic is
60.
yep. Based on that, our aortic regurgitant index, this will not require any. Okay, ready?
Ready,
Okay.
ready, ready.
Yep. Fluoro, let's go. Let's do it. Good.
Is it
Inject.
Sina? Is it?
Sina?
Yeah, yeah, inject.
Oh, it's a 1+.
I think it's 1+, but it's less than before.
Oh, way less than before.
And I
Let's
think
show it
this
what it was
valve will
before.
continue to expand. I'm not sure it's worth the risk of a 30mm balloon here.
Yeah. See, this
Um,
was before, and see the cage. Basically, it's a wide open 3+, and the cage.
Constricted
Then one
cage, yeah.
was very constricted. The nicely dilated here. You see that expanding with the balloon inflation, and now this is what we have now. 1 plus, we also know that this should going to get less because dye goes in, incomplete opacification, then clears up. So by definition is 1.5 plus. By angiographic definition, the echocardiographic definition is with the part of what he says.
No, I think it's a team decision. Overall, the risks of balloon dilatation, the hemodynamics, and the echo, the integrated information. I think if the risks of the balloon septal hypertrophy, and sometimes we might have to call it a day at this stage, and it's acceptable.
I think taking everything together, we are done here.
And most important here is the diastolic pressure. That's the key. The diastolic pressure good, so that now I think from the procedure point of view we are done. The diastolic is 65-70 before we, better than what we started with.
And also at this time another important you can look at is the PA pressure. Like Amanda just said, there's no change in PA pressure. Pre and post PA pressure is the same. Just about 40, 45-25. That's what we started. Yeah.
Yep. Ani, you're the last word. What do you think?
Yeah.
We do any further or we stop here?
I think also, I think this is a good result for an elderly patient, high surgical risk. So I think it's a good result. I mean, one question people might ask is why we didn't just do surgery. This patient's risk with a surgical operation might be about 10%, which is not much different from with the catheter valve. But I think what's changing things is the results of the CoreValve study, which have shown that at 2 years, a bit concerning for me as a surgeon, that the curves of the TAVI and surgical AVR are separating with superior survival in the catheter group. We don't know how this will go into the long term, but for a patient in their late 80s or mid 80s where you're looking at a 5-year life expectancy to 10-year life expectancy, the long term might not be that critical, and in most of these patients we're moving more towards the catheter valve as the treatment of choice as opposed to a high-risk surgery.
Okay, great point. Okay, so then now, while JK will do his the usual magic about closing, meticulous closure of our vascular, I can go back to our slide presentation of next. Our plan today, next slide, was to discuss about next the neurologic complications and the potential preventive strategy after TAVR. Next.
Yeah.
Now clearly that neurologic complications do occur, and the numerous studies have said, and more importantly that if they occur, they're associated with threefold higher mortality at 30 days as well as at 1 year. The partner trial also showed that 1 year threefold increase in mortality from let's say 7% to 25%. Next, clearly we know that at present, as Ani pointed out with our high-risk pivotal trial which was presented by Dr. Adams last year, published in NYHA, that TAVR no longer has a higher CVA rate. Next, but still your major stroke rate is about 6-7%. So it still happen. Next, and then we of course the choice, next slide, the comparative of both balloon expandable SAPIEN and the of the CoreValve, that yes, the CVA does occur. The major stroke was 2.6% in the core and 5.8% in the balloon expandable SAPIEN, but it still occurs in the fairly good number of cases. Now, why? What is the good number? You know, with the PCI, our stroke rate is less than 0.2%. So clearly that does occur. Next, and more important point is that this occurs usually, stroke occur peri-procedure. Majority of strokes occur peri-procedure, both in the France registry and subsequently, and later on continue to occur. You say, well, why? You have done the valve, then why there should be continued occurrence of the stroke rate? And then part of that is that some changes, one maybe a loose atheroma which we leave, but also some irregular, the heart rhythm irregularity. Next, and that actually have been shown. There's a very nice review paper by Windecker group in circulation a couple of years ago, which talks about the acute, subacute, and late and the stroke and various mechanisms in the bottom to kind of how to deal with it. Now clearly the acute is associated with TAVR, the implantation of the valve, and there what you can do various techniques like minimal touch technique, small devices, the newer devices, and of course the embolic protection devices. Now then you go to a subacute, and that subacute region for the stroke is not clear. Whether it is just because of the hemodynamic changes occurred during the TAVR procedure, like this patient, we kept few minutes episodically the blood pressure of 70-80, and these people have all compromised circulation. So maybe in the watershed area of the brain, they develop some stroke. So clearly, the subacute phase, which happens in about 1 week or so, not very clear. But what is clear is, once you go beyond 1 week, studies have shown that stroke after 1 week, strongest correlate is your atrial fibrillation, occurrence of the atrial fibrillation, new or old, and therefore our strategy changes. So basically what we learned, that of course acutely you do an antiplatelet therapy, and this is the whole field which will evolve, I would say, in my opinion, in next couple of years, that can you start anticoagulation or newer, particularly the anticoagulation, the novel agents earlier, knowing that they are associated with a lower bleeding, because our biggest concern has been the bleeding by giving the anticoagulation. So clearly this issue still need to be evolving, but remains that yes, we know the region, and of course many of these patients have atherosclerotic disease burden. They will have spontaneous stroke. I have a case about 15 months ago, patient supposed to have a TAVI, but that morning developed a stroke. So spontaneous, didn't even, just was on the cath lab schedule. So it's not that these patients may not develop stroke, may just develop because they're intrinsic disease. Next. And of course various mechanisms, atheroma, valve embolism from the valve, and that actually have been shown that all this material from the valve, calcium, thrombus, a lot of necrotic material goes up, and that creates the problem. Next. Clearly the stroke is associated with, obviously, with various disabilities. Next. Besides having a higher mortality, and also have been shown that your silent brain lesions which occur, they are not benign. And I think the field in last 4 or 5 years has really evolved to identify the silent brain lesions which occur with various cardiac procedures and what is their impact. But clearly it seems to be, next slide, that even the silent brain lesions are associated with neurologic dysfunction on the late and maybe even dementia. Next. Now, the silent brain lesion has been shown that they occur tremendously higher number with the prosthetic our TAVR valve compared to surgery. Surgery, this is the MRI, the numerous studies have shown, this is the MRI, 50% occurs with the surgery, but 80-90% with CoreValve or Edward. But what they found also, that once you have the new cerebral infarct, the volume of the infarct with the TAVR is small, with the surgery, the volume is high. You can see there that the lesion volume is higher, although they occur less frequently with surgery, but definitely higher with the surgery versus TAVR. Next. And now we actually in the era of embolic protection devices. 3 of them are available. Cerebral protection system of the Claret Sentinel, Edward Umbrella, embolic deflector, and the Triguard cerebral protection devices. Idea there is that either you capture it or deflect it from going into the great vessels. Next. And we actually have, there are a few others which are in being development phase, and you can see that there's one of them actually has the entire aorta, aortic arch jacket. So you basically during the procedure, so you capture all the embolic material. Next. Now, what has happened so far, the Claret Sentinel cerebral protection system is far ahead in terms of the clinical data, and this looks a little fancy, looks like maybe it's a very difficult device. It's a U-shape. You have to put deploy the one filter in the ipsilateral vessel, goes to the radial, and then goes to the second side of the left carotid. But it seems to be that difficult, but I can tell you we have used 5+ cases. It's such a simple device. It's a really credit to the engineering of the device, that how easy it is to deploy, and it takes only 2 minutes, maybe 3 minutes maximum. So despite being complexity, and this is the data from CLEAN-TAVI. Next. And showed basically 96% they were able to deploy. Next. And of course majority of them, they had embolic material. A small study of the 100 patients from Leipzig. Next. And basically showed, and this is a very important slide, that clearly that the areas, total lesion numbers at 2 and 7 days, there was significantly decreased with the device which is the filter, which is the green bar versus to control of the yellow bar. Next. And also in terms of the neurologic outcomes, ataxia was significantly lower in the filter group, 9% versus 24% in the control group, although there was a trend towards lower other neurologic symptoms in the device. A small series of 100 patients, but it's really proof of concept. Next is basically showing that there was no difference in procedural complication or mortality, but see a trend towards lower clinical neurologic event. Major next slide is the Sentinel study, which we are part of it, and that after the roll-in, it's going to answer this question. And the question comes, the procedure itself is very complicated. No, go back to the slide, please. Yeah, the procedure itself is very complicated. Now, do you want to add another procedure for these patients? The question will be answered by this major Sentinel trial of about 300 patients. One will be that you do a TAVR with the Sentinel just as a clinical endpoint, and of course you have 30 days and so non-inferiority. More important is that you do a TAVR with Sentinel or you do a control TAVR only, and all those patients get the MRI. Idea is to see the new lesions, the new volume of lesions, and so with MRI assessment. And because we know that in order to show the stroke difference, you may need 2,000 patients, but the 300 patients should be good enough to show that yes, you reduce the median total new lesion volume from patient at 4 to 7 days by the diffusion weight MRI, and that's the primary endpoint. And to me, this will be kind of a first baby step in this field, that yes, by decreasing the silent infarct, the new lesions, less volume, you'll be associated with a lower CVA once you start using them routinely. Next. And also studies now have enough studies have come, like in this particular case, you may have to do a balloon dilatation, but has shown that balloon post-dilatation is definitely cause more CVA. But sometimes, is it because there was a calcium? So was it the balloon post-dilatation in the multivariate predictor is the issue, or it's the calcium because we didn't let the valve to expand? So we don't know that answer. But one thing for sure, the studies have shown, you take a TAVR group, balloon post-dilatation and no balloon post-dilatation, the balloon post-dilatation has almost a 3 to 4 times higher stroke rate. There has been no difference in mortality in these studies. Next. And therefore, if I sum it up, the major or minor stroke still occurs in 4 to 10% of TAVR procedure, and silent brain lesions occurs very commonly in about 80% of cases. Next. And besides decreasing the device and sheath size, in my opinion, you saw the data of the SAPIEN, maybe I'll discuss during our next presentation. We'll have an advert valve, SAPIEN XT implantation in our next webcast. That SAPIEN 3 data are very powerful. The stroke rate, major stroke rate at 30 days was just 1.2%. So it may be just the lower sheath size. Now similar data is from the Evolute R also, although they have not really, Medtronic has not really advertised that because there is a small number of cases. SAPIEN 3 were 1,000 patients in the intermediate risk group, CVA rate of 1.2%, major stroke at 30 days. So clearly that this field is evolving and decreasing the stroke rate, and largely because of the smaller device and sheath size. But clearly the cerebral protection system has a promising data to reduce new neurological microinfarct after TAVR procedure. With that note, we'll go to our 3 questions. Question number 1, that following are the true statements regarding strokes after TAVR, except most stroke occurs in first 24 hours. Delayed strokes are likely due to AFib. Balloon post-dilatation has not shown to increase strokes, and major stroke occurs in 4 to 10% of cases with current devices. Next. The following are the true statement regarding silent brain infarcts post-TAVR. Incidence is less than 50%, 50 to 75%, 75 to 95%, more than 95%. Third,
Everything is C.
CLEAN-TAVI evaluating Claret embolic protection system versus control group post-TAVR showed all of the following except reduction in new lesions in MRI, reduction in volume of new lesions on MRI, reduction in ataxia, and higher procedural complication with the device. Actually, there was one question was posted on the website, and that's that we don't give them the answer of our old ones. Next. So I have answered, I said, you know what, we will be giving you answer right then and there, that particularly the answer here in this case is C, that balloon post-dilatation has shown to increase stroke. So that's a false statement. Next. Again, brain infarct 75 to 95%, silent brain infarct. Third, and
D.
that claret is not associated with higher procedural complication with the device. Next, I think I still have the last month webcast question. Remember that one was the true BAV pre-TAVR in extreme risk AS patient. That what was the true statement? 1 year mortality is lower than BAV, CV incidence is higher than BAV, mortality is lower is at 3 months but not at 1 year, and mortality and CVA both are lower. Next, in this scale, clearly the answer was C. That studies shown that in the partner trial, the BAV pre-TAVR has a lower mortality at 3 months but not at 1 year. Next question, this is the question of the April, these all three of them. Second was balloon post-dilatation is required in what percentage of TAVR patients? 15 to 25, 40 to 50, 50 to 75, and more than 60. Next, and clearly answer is A. The much lower with the Edward valve or Sapien valve and much higher with the CoreValve, but still about 20-22%. The third question of last month was balloon post-dilation post-TAVR may be associated with the following except valve degeneration, higher mortality, higher CVA, and lower prosthetic regurgitation. Next, clearly is answer is A. That we don't know. So far, they have looked into it. The patients who have balloon post-dilatation, the reports have been that there is no increase in gradient or valve degeneration by the balloon post-dilatation, so that if required, we should not worry to do the balloon post-dilatation, although limitation I showed that it may increase the stroke rate, but that may be just incidental because there was a very calcific valve. So with that, I finish my presentation for today.
Enough. You're past and 10.
Yeah.
Well, this
So
was a
much.
great case. Went as planned.
Yep.
It
And,
was a very careful planning.
and JK can tell us clearly in 1 minute. We are done with that.
Show the
Yeah.
angios, please. So while Dr. Sharma was talking, we took the sheath out in essence. So just show the cinae. I'll just take you quickly through the steps of that. Show the angio, please. So the first step is to very carefully just withdraw the sheath on the wire, making sure we're not dislodging any calcium. There's nothing moving. The sheath came out very easily. There's nothing moving in the vessel there that you can see. The next important step is this DSA. So now we've got the sheath withdrawn to just the external iliac. We're doing a DSA run to make sure there's nothing perforated, no problems. You can still see we have bilateral access with a stiff wire on the left side where we had the main sheath. So no perforation, no problems. Now I've actually withdrawn the sheath and deployed the per-closed sutures, but I still have the wire in place if there was any trouble at this point. You can see again, no perforation, good hemostasis, and no problems at the access site itself, no pinch or extravasation. And a final shot here, everything's out, wires out, sheath out, nice result. So very pleasing.
Yep. And
Good.
and the right side also.
The right side will now just withdraw. It's a 5 French access. You can either do manual if it's disease or just put a per-close or an angioseal. That's very simple. The patient has a pacemaker, as we said before, so we just, the pacemaker, temporary wire comes out immediately, swan is out, and the patient should be up and moving later tonight or early tomorrow.
Great, very successful case, as we said, from all aspects, a lot of planning. We saw very interestingly that high quality echo, high quality CT coincided in the assessment of the sizing. We were very careful around the septal bulge. We had a lot of discussion about that and a lot of imaging. It turns out that this wasn't a problem. The valve was deployed at a depth of about 2 to 3 millimeters and likely just above or at the beginning of this bulge. That did not play any role. We went through the steps of the post-dilation very carefully, and we did a successful post-dilation with a 28 millimeter balloon according to the smaller axis of the CT angiogram annulus size, and that went out very well. We anticipate over time these valves expand, and therefore the regurgitation may decrease. Dr. Kinney made a great point in that the PA pressure staying rock stable towards the end of the procedure is another testimony of the insignificant importance of the regurgitation into this patient's hemodynamics. So all went well. The closure went actually very well with a double per close. And I think it is time that we leave you after thanking the team in the cath lab, Dr. Sharma, Dr. Kinney, Dr. Kovacic, Dr. Agneanu, and our fellow Dr. Tere. And I want to leave you with a couple of reminders. First of all, the next structural heart disease webcast
August 11th.
is going to be on the August 11th, which is a Tuesday, at the same time wherever you may be around the world. And next week we have a series of events starting with a coronary webcast at ccclivecases.org. The same time again on Tuesday morning here in New York or anywhere in the world, the same time you watch this show today. And then on Wednesday, Thursday, Friday, we have our live case course and obviously around it many lectures, which is going to be at the Equitable Center at Times Square. And we invite everyone who can make it to New York to come and attend it in person and meet all of us, and obviously see many, many vascular, valvular, structural, and of course, coronary live cases. Goodbye from New York.
All right, thank you.